Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConell from Victoria University in Australia. The idea behind Inside Exercise is to bring to you the absolute who's who of exercise research. So exercise physiology, exercise metabolism, and exercise and health. And what I'm really wanting is for you to get your exercise information from the research experts rather than from influencers. And indeed, today I bring to you Emeritus Professor Paul Thompson. Paul has for many years been the Chief of Cardiology at Hartford Hospital and Professor of Medicine at the University of Connecticut. He has recently become Emeritus, so he's retired from that. But as you'll see, he's not particularly good at being retired, so he's still going in there quite a lot. He has a remarkable track record. So somehow, while being a cardiologist, he's published over 500 peer-reviewed journal articles. And also, he's been past president of the American College of Sports Medicine and was a mid-220s marathon runner. So he's very credentialed, of course, to talk about exercise and sports cardiology. So we talked about exercise in the heart generally, but we focused a lot on, can too much exercise or a lot of exercise actually cause negative effects to the heart? So there is evidence that people that exercise a lot have increased atrial fibrillation, which we go through and discuss, and also increased coronary artery calcification. So coronary artery calcium scores. So we talked about that, and this is a great follow-on from the previous podcasts I've had. So I've talked also about this sort of topic with Professor Benjamin Levine and Associate Professor Andre Gerche. So this is a great follow-up. So I'd suggest that you actually listen or watch those two podcasts first to get really the full context. I found them very personable, really enjoyable chat. I learned a lot. I think you will too. So stick around. Now, if you'd like to do me a favor and also increase the awareness of Inside Exercise, can you please like, subscribe, leave a comment, etc., leave a review, and that would help get the word out. So if people do a search on exercise, it'll be more likely that they'll be suggested Inside Exercise. And finally, you'll see if you look down in the notes, you'll see that there are timestamps. So if you're on YouTube, the times will be shown in blue. You click on them, it will take you to that point. On the other platforms, you can just move manually to that point if you're interested in a particular topic. But as usual, you'll get a lot more out of listening to the whole podcast to get the full context. Okay, so enjoy the chat with Paul Thompson. Hi, Paul. Welcome to Inside Exercise. How are you doing?
I'm doing well, Glenn, and thank you very much for having me. I'm actually honored to be included with all those heavyweights that you've had on before me.
Oh, you're definitely a heavyweight as well, as we'll find out as we chat. But yeah, I wanted to say I'd encourage people to have a look at the other two. Well, we actually had three. So we've had Andre Gerche on talking about exercise in the heart. Before that, we had Ben Levine, a massive name in exercise science. And also I had a really interesting chat you may have seen with Mark Hakowski with two amazing heart transplant recipients who have both done Ironman races. So if people haven't seen those, I'd encourage them to have a look at that. And we'll be referring to those as we go along. Did you happen to see any of those?
I saw parts of them, but I didn't see all
Yeah.
of them. As you say, I am retired, but it's not like I'm looking for things to do.
No. Well, this is the thing I'm a bit confused about as well. So while I was trying to line you up for the talk, you were saying, oh, I'm retired or I'm retiring on Tuesday and things like that. But you kept saying you've got all these meetings and you're seeing patients and whatever. So are you retired or?
So here's a quick summary. So I see patients 2 days a week. I am retired. I'm retired as the chief of cardiology and professor of medicine at UConn. After I retired, I worked 1 week a month at Mass General in Boston with their cardiology trainees. And then I did that every other month, but that was too much. So now I work 2 days a week at Hartford Hospital, where I was the chief. And I'm covering 6 weeks of either the consult service. So 6 weeks I'm actually in the hospital the whole week. But generally, I do 2 days a week. And then the other thing I do, Glenn, is I write this blog called 500 Rules of Cardiology. And it's primarily for clinicians, people who are in medicine, but it's about little tricks I've all short. They're all 1 to 3 minute teachings about something.
Wow.
But they're just little things that I've used. For example, this is cardiology, but the cause of the pause is a blocked PAC until you prove it otherwise. So they're little simple rules that I've used all my life to help me remember things.
And where can people find those if they want to look that up?
And Substack, It's under
Okay.
Paul D. Thompson, but it's called 500 Rules of Cardiology, which I admit is presumptuous on my part, but that's what I call
Well, it sounds great to me. All right. So now I was actually saying I wanted to hear the story. So before we started recording, I was saying to you, how much time do you have? And you said, as long as you've got, you're the boss and all that, which was lovely. And I said, started off, they would go for an hour. And then I found if I was having fun, I assumed that people listening were having fun. So I'd go longer and longer. And I said that the longest one was 2 hours 12 with the legendary David Costill, who was my master's supervisor at Ball State and just an absolute legend. And then you said you've got a story about David Costill. I said, hang on, let's talk about that on air. So what were you going to say about
So
that?
here's the story. I was a first-year medical student. I read in Runner's World about this guy, David Costill at Ball State. I wrote him a letter and asked if I could come for the summer. And he said he had a American Heart Association scholarship and that he could pay me for the summer. So I
Right.
flew out to Indiana, and in the airport, he picked me up. And I said, "Oh, what are we doing this summer?" And he said, "Muscle biopsies." And I said, "Oh, really? That's interesting. In whom?" And he said, "In you." And so it was,
You. Okay.
and I just flown into Muncie on this little
That's
puddle
funny.
jumper, and it was up and up and down. And when he told me I was about to be biopsied, I got a little queasy. But the story is that it was one of his first studies on glycogen loading. So we would
Wow.
get a muscle biopsy. We would then run 10 miles. We'd come back, get another muscle biopsy, and we'd do a maximum oxygen uptake. And we did that for 3 days in a row. And then you glycogen loaded for whatever number of days. And then 4 days later, you got another muscle biopsy. So it turned out to be, first of all, I learned a ton with working with Dave, and he was very nice to me, and we've stayed friendly since then. But also later on in my career, I did a lot of muscle biopsies as part of our studies of how statins affect
Statins.
our muscle. And so
Mm.
when subjects would say, "Oh, I really don't want to have a muscle biopsy," it's nothing. I had 7 in a week. It didn't bother me a bit. You want
Perfect.
to feel my thighs, you can still feel the holes.
Perfect.
So it's interesting. I always think, Glenn, that nothing that you do turns out to be useless. And so that experience with Dave
Mm.
was more than useful throughout my career.
Absolutely. And that was way back in the day. When was that the 70s?
It was 1970. It was
19.
1970. It was quite a famous picture of the I think it was the 7 of us that were in the lab that summer on a motorcycle, because it was the days when you didn't have long hair and you didn't ride a motorcycle in Muncie, Indiana.
Oh,
So
right.
it was an interesting summer.
Wow. So was that, we're getting a bit nitty gritty. Was that Phil Gornick? Was Bengt Saltin? Because I know you said in an email to me that Bengt invited you out to, yeah.
Uh, yeah, that's a different story. Bengt Saltin had asked if I would like to spend a year with him, the year or two that he was not in Copenhagen, but in Stockholm. So
Mm.
we wrote a grant together, and the grant didn't get funded. And then things came up with me personally. Some family members got sick, and so I never went. But that was my contact with Bengt Saltin. It's interesting, I'm sure there are a lot of people out there with careers, but you look back over your career, and if I had done that, what would have happened?
Mm.
The rule is there's no control group in life, so you can never say if I had done this.
That's true. You don't know that.
There's no control, and you might have
That's
got
true.
hit by a bus in Stockholm. So things worked out pretty
Wow.
well.
Now, I saw you've had an amazing career, obviously, because I saw you've had more than 500 published journal articles. I was just thinking, how do you do that when you're, a cardiologist full time? Like, how do you? Because if you're just straight researcher and you're not working,
So yeah, I'm not a straight researcher. I've got over 500 publications, probably more by now. And I think the way you do it is that you do things you like. So I always did things that I liked, and I was always very careful that I finished things.
uh,
So if I did studies, I wrote them up. Now, I want to point out one other thing, which I'm really quite proud of. I was never at the biggest of institutions. I was at Brown University for 14 years. I was at the University of Pittsburgh for 5 years. But really, most of my career has been here at Hartford Hospital in Hartford, Connecticut. And it's not a big research institution, but I was able to find my way and to find things that interested me. And that's how I wound up with a lot of publications. Now, early in my career, I was not very collaborative. I was really competitive. And I think that was a hangover from, having been a competitive distance runner and kind of
mhm.
always
Mm.
being wary of people. But as I've gotten older, I've been able to collaborate, and I've had some wonderful collaborations. Right now, I collaborate with a guy named Thijs
Yeah.
IJsvogel from the Netherlands,
Netherlands.
who spent 2 years with me, which is in itself an interesting story. He wanted to come work with me for 2 years, and I said, look, you don't want to come work with me. You want to come work with somebody who's got a big research lab, who's got a
Mm.
lot going. And his mentor said, no, we want him to work with you. And she actually flew over to try to convince me to take him, which I did. And it's
Wow.
been great for my career, but
Yeah.
also it's been great for his career. Because what I got him interested in is could there be bad effects from too much exercise? Could there
Mm.
be deleterious effects? And it was just, I always wondered about that. Because the heart can get quite large from exercise training and stuff like that. And it was just a good time. It's turned out to be a good career move for both of us.
Yes. Now I saw that name over and over. So you've done a whole bunch of stuff, and I've got some. I don't know if you saw. I sent through some dot points and things, and also some questions that came up on Twitter, and some of those with a collaboration with him. But I'm interested in that because again, I've had the chat with Benjamin Levine and Andre Gerche, and that was the major focus. So just quickly for people that Benjamin Levine was the first one. So there's a lot of background just about, what happens to the heart during exercise and why is it good for the heart and just how does endurance exercise increase the left ventricle mass and all sort of basic things. But then we got into him talking about how doing a lot of exercise can increase your CAC score, so your coronary artery calcium score. And then he touched on can it increase atrial fibrillation, but he said, look, talk to Andre Gerche about that mainly. So I spoke to him about it. And then you've just brought it up. So this concept of a lot of exercise may actually cause deleterious effects, and whether they are actually deleterious in the end, because if you end up living longer anyway, dot, dot, dot. So I'm just wondering, who was the first to sort of come up with that? Was that actually you that was the first to come up with that concept that can too much exercise be bad for you? Uh,
I don't think
oh,
we
no,
were the
not bad
first.
for you. Sorry. Can it have effects that look bad? Anyway.
You say, can it have deleterious effects on the heart? I'm not sure I was the first. I think I was among the first. Way back in 1979, I wrote one of the early papers on sudden death during exercise. And then
Okay.
subsequently, we were able to calculate how many deaths there were jogging in the state of Rhode Island. And then in 2007, I think I was the first to put together, to do a summary of papers in the literature that looked at atrial fibrillation. So way back in
Okay.
2007, we looked at the literature, we did a literature search and found 6 papers that had compared the rate of atrial fibrillation between athletes and non-athletes. And we found that all of those 6 papers said that the atrial fibrillation was more common in athletes. Now it's interesting. In 2007, I could not get that paper published.
Wow.
People
The
didn't like it.
dogma.
Finally, I
Mm.
published it almost as a desperation move in 2007 in a good journal, the British Journal of Sports Medicine. But
Mm.
it's not the British Journal of Cardiology. And it's not the
No.
American Heart Association. It was
Mm.
rejected from all those places. We
Wow.
think that atrial fibrillation, at least in men, is more common in lifelong endurance athletes. And if you ask me the mechanism, because there are potential mechanisms, I think it's heart size. If you do a lot of exercise all your life, especially if you start young, your heart's bigger. And one of the things that gets bigger is the left atrium. And the thing we know about the left atrium is that if you make it bigger, it tends to fibrillate. Now, what's fibrillation? Well, the normal contraction is goosh, goosh, goosh,
Mm.
but fibrillation is quiver, quiver, quiver. So it
Mm.
doesn't move the blood around. It's like a muscle spasm. So
Yeah.
it doesn't squeeze the blood around. And that can lead to blood forming clots in the atrium. And then those clots can come out, go into the ventricle, the big pumping chamber, and go to your head. You give a stroke. And that's the big problem with atrial fibrillation caused strokes. Now, those strokes with atrial fibrillation are much more common in sedentary people. But runners who have atrial fibrillation or athletes who have atrial fibrillation have more strokes than runners without atrial fibrillation. So it's not totally benign. We think it's due to the heart getting enlarged. Now, remember, too much exercise is not our public health problem. Our
No.
public public health problem is that people aren't getting enough exercise. But, you know, people who do a ton of exercise like I did when I was a kid, I wasn't doing it for its health benefits. I
No.
was doing it to beat the guys I was running against.
Yep,
So
yep,
you
yep.
got to make sure you get your purposes right. If your purpose is to be competitive, to be a competitive athlete, you got to do tons and tons of training. You got to do lots of interval training. You got to work hard. You got to run long if you want to run long. You got to run fast if you want to run fast. You got to run long and fast if you want to run long and fast.
Yeah.
I mean, simple physiology. On the other hand, you don't need to do that much to be quite healthy.
Yes. All right. So there's a lot to pick apart there. First of all, can I get the mechanistic part there? So you said if you've got a larger heart, you tend to have more atrial fibrillation, and you think that's causative. Has there been some sort of studies, you know, in animals or something where, like, how do you actually look at that to get that causative relationship?
So I don't know the answer to that in athletes. And I don't know whether there's been a study where they've measured left atrial size and said, oh, these guys are more likely to have atrial fibrillation. But in general, as a rule, as a cardiology rule, the bigger the atrium, the more likely it is to fibrillate. And
Okay.
that's also true. That's also true about ventricular fibrillation, you know, sudden death. You know that old thing, the taller they are, or the bigger they are, the harder they fall.
Oh, okay.
The bigger they are, the bigger hearts they have. The bigger heart you have, the more likely that not only the atrium, but the
Ventricle.
ventricle will fibrillate more frequently. You know, atrial fibrillation is more common among basketball players. Why? Because
Okay.
they got big hearts, they got big
Okay.
atrium.
So
So
even,
there's not any direct data that I can give you, Glenn, but there's lots of indirect data.
oh, so just literally the size of the heart, not even like relative to your body weight. It's not even like the mass divided by your body weight. It's just if you're a big person and you have on average a bigger heart, you'll have more fibrillation.
Yeah, you know, in the United States here, there's there are a lot of people, NBA greats, who have had atrial fibrillation. Larry Bird, for example. I
Mm.
don't know the details of it. And I couldn't say where the paper is, but I've seen it in reports. A lot of basketball players. Now, have I seen a study that compares their frequency? No, but I wouldn't be at all surprised that it's much more common in big people.
Okay. And also when we think about endurance exercise, for example, so which is what we're tending to assume here with well, with the bigger hearts, but you're just talking about basketballers as well, so that's different. But if we think about for someone of the same height, for example, and they're exercising, it's more the endurance people that get the bigger left ventricle, for example. And I guess I wasn't aware that you're actually getting a bigger left atrium as well. It's not just the ventricle.
So everything gets big. You know, if
Okay.
you're a good endurance athlete, what typifies you? An
Mm.
ability to eject a lot of blood,
Hmm.
what we call a stroke volume. If I see somebody that's a great endurance athlete, without checking anything, I know they've got a great stroke volume.
Hmm.
So if you've got a big stroke volume, you got to have a big heart to squeeze that out. You got to have a big engine. You got to have a big pump to do that pumping. So if your left ventricle, the pumping chamber, is pumping out a lot of blood, then it's got to be filled by something, the left
Yes.
atrium. That's got to be big. The right ventricle's got to be big, and the right atrium has got to be big.
Okay.
So to be
Hmm.
a good endurance athlete, you're big-hearted,
Hmm.
and you're big-hearted throughout all
Throughout.
chambers.
Oh, that's interesting. All right. So all right. So I'm interested. You're saying the left atrium is bigger, and you get a lot of so atrial fibrillation, and then as you said, the right atrium. So is this the same idea with the right atrium as well? With the sorry, with
Yeah,
the right with the no, anyway, yeah.
yeah, the right ventricle is bigger as well. Now, this has some implications in certain
Mm.
patient groups. Now, I don't expect your audience to know about this, but there is a condition in which people are born in which their heart muscle doesn't stick together. So let's say that this is one muscle and this is another muscle. For the heart to work well, those things have to stay connected, right? They
Mm.
have to pull together. So there's a little thing in here that keeps them together. It's part of the same stuff that keeps your skin together. It's called the desmosome.
Mm.
Some unfortunate people are born with the gene that leads to defective desmosomes, so they pull apart. And these people if they do too much exercise, get their heart disease earlier than if they didn't do their exercise. So, for example,
Okay.
here's what happens to regular people in terms of getting their disease. Here's what happens to endurance athletes in terms of getting that disease. Much faster getting the disease, much quicker downslope. So there are conditions where this can affect some people deleteriously with certain diseases. The question is, are there other people who can have bad effects from too much exercise? Now, I didn't hear everything that Andre and Ben said.
Mm-hmm.
Remember that endurance athletes in general, despite these problems that we've talked about, live longer.
Exactly.
Now, do they live longer because of the exercise, or did they choose to exercise so much because they were genetically endowed,
Mm-hmm.
right? Like you don't, there are some people that come out of the womb ready to run. I mean,
Yeah.
there are some people that you know the kids that are good in high school. And so a lot of it is effort, no doubt about it. A lot of it is training, but it's also a lot of it is genetic endowment. And I know exercise has lots of beneficial things, but to get really, do you choose to exercise or do you choose to exercise because it's easier for you?
You're good at it. Yeah, exactly.
And I don't want to
Yeah.
go through all this, but there are a bunch of studies. Let me give you one study that was done a long time ago, 30 years ago. Paul Williams, who was at Stanford, did an exercise training study. And he showed in an exercise training study that the men who exercised the most increased their good cholesterol the most.
Mm-hmm.
But the men who exercised the most also started with the highest good cholesterols.
Mm-hmm.
So the rich got richer. Do people who become incredible endurance athletes, do they start richer in endurance athlete ability at the beginning? I'm not sure. Now, don't get me wrong. If there was one public health thing that people could do that would make a big difference in their lives, it would be to exercise. Now, I didn't say run the Boston Marathon in 2:15. I said exercise. So I think we need to remember to separate the beneficial effects of exercise and all that sort of stuff from being an endurance athlete. You know, when you're an endurance athlete, you make sacrifices, whether that be to your knees or your hips or whatever. Most of my friends that I competed with when I was younger, are having stuff done to their knees now.
Hey, that's interesting you said about the people with the higher HDL tended to increase their HDL the most, because it reminded me of another podcast episode that people should ever listen to, which is Claude Bouchard. And he actually said, if you look at the genetics of what determines your VO2 max, you can get, sorry, what is it? Okay, about 50% of the determination of what your VO2 max is if you're untrained is genetics. And then if you train, about 50% of what determines how much you increase your VO2 max is genetics, but they are separate. The genes that determine your basal and your training effect are separate. So it's interesting that you've got a situation where it's like maybe your genetic rationale for the high HDL is the same. You know what I mean? They're kind of going hand in hand. But yeah.
I do. I think that there's stuff that makes you genetically interested in training. You know, like Irish setters love to run. You know, the dog, the Irish setter loves to run. It's bred into them. You know, so I think there are a lot of things that where genetics has an influence. I'm not undermining the effect of training, but
No, no.
there's some people that could train like the Dickens and they're never going to go to Paris for free, as we say.
Exactly. And then as Claude talked about, you're not going to get someone that's a great distance runner who, you've got to have the high basal sort of VO2 max, and then you've got to have the trainability, which is the hard thing, to have both, right? Now, talking about, we've been sneaking around your former running days. You went to the US Olympic trials and you were a 2:20 marathon runner. Is that correct?
No, I was in the 220. I was in the high 220s. I was
Okay.
trained. I ran in college. I really wasn't very good. I was okay, but I really wasn't very good. And one of the reasons I wasn't very good is I always did this when I was a medical student. I always knew where my bread was buttered. I would be
Right.
paid for being a doctor. So,
Mm.
but I was always very interested in distance runner. One of the great regrets of my life is that, in my heavy training days, I would run maybe 80 miles a week, whereas most of the people I was running with would running 100 and 120. But I remember when I was training at Stanford, did my cardiology training at Stanford. And one week I ran 100. I decided I was going to really take advantage of things. I was going to get better shape. So I was going to run 100 miles. So I ran 100 miles and I was in clinic that Monday and I did a terrible job. And my attending said to me, you weren't very good with those patients today.
Right.
And I remember saying to myself, yeah, I'm exhausted.
There you go.
I'm not going to be able to do this well and that well. So but I ran in the 220s, the high 220s, ran in the 72 Olympic trials, which, was nice. The year I think I could have done well. I was 16th in Boston, but it was the only year I was not on call, 1976, but it was 104 degrees at the start. I ran 229. Jack Foltz won in 221. He ran 214 the next year. I didn't run. I ran, that was the only year I wasn't on call all at night. So I had a lot of time to train. Generally though, during my career, when I ran competitively, I was on call either every other night, every third night, or every fourth night. I was actually in the hospital.
So you might have a race in the morning and then you get a call during the night at 3 a.m. and then you got to front up the next day for a race.
It was less that and more simply the time to train and the time to, so what I did during medical school and actually during most of my training is I ran to and from work. I would always buy houses that were 6 to 10 miles from the hospital and then I would run in and run home. But, 6 miles, it was about the distance I would do in and out because much more than that, you just got too tired.
Mm-hmm. All right. So now when I sort of stumbled around a bit talking about the left atrium and the right atrium, I was actually thinking about Andre Gerche's chat. He was saying that he finds if you do like 6 hours or more of high, so like an Ironman or something like that, but at a high level. So it wasn't just if you did 8 hours, 10 hours of exercise. No, if you're doing 8 hours, 10 hours of exercise at a high intensity, so you've got a high cardiac output. He said he's seeing actually right atrial problem. Did you want to just take us through that and see what you think about that?
I think probably what he's saying right ventricular dysfunction.
Oh, that's what it was. Right ventricular. That's right.
Well, here's what happens. We talked about the fact that if you're exercising, you need to be able to generate a lot of forward output. You need to be able to pump a lot of blood. That requires all the chambers to be enlarged and to squeeze a lot. Now, when the left ventricle, the main pumping chamber of the heart, when you exercise, the blood vessels in the legs open up. So the resistance goes down. So it's the left ventricle is working hard. It's pumping out a lot of blood, but the resistance is going down. So it makes it easier, we call it unloading it. Yep. The right ventricle also has to pump blood. Where is it pumping it to? Well, it's basically pumping it into the box of your lungs. Your lung blood vessels can't expand anywhere near as much as your leg blood vessels, your peripheral blood vessels. So the right ventricle, which is thinner walls, is now asked to squeeze a ton of blood into that box, into that resistance. So Andre has done incredible work showing that the right ventricle looks fatigued after the race. It doesn't squeeze as well after the race. And that's interesting. And that's what I was talking about, those people with that connection in the heart. Those people, because the right ventricle has to work so hard, it used to be called right ventricular dysplasia. In other words, dys means bad, plasia means plastic. So right ventricle changing in a dysfunctional way. And Andre's done a lot of work on that. He's not the only one. Way back in 1990, a woman named Pam Douglas, who went on to become the chief of cardiology at Duke, she studied the people in the Ironman, the Hawaiian Ironman, and she said, looks like the heart is fatigued. Now, why do I remember that? Because I was the reviewer for that paper, and I did not like the concept. I did not like the idea that the right ventricle.
So you're one of these people rejecting these other ideas.
Yes, that was it. No, I actually accepted it. I accepted it, but But
Mhm.
I mean, I pulled them over the coals to make sure they answered all my questions because I found it hard to accept. But quite frankly, as you know, as I've gone on more in life and training, it's amazing the things we think we know that we don't know.
Exactly.
There's a famous, I'm sure you know the name Mark Twain. Mark Twain was
Mm.
from Hartford. He lived in Hartford, but
No,
one
yeah.
of his favorite sayings was something like, "It's not what you don't know that kills you. It's what you know for sure that just ain't so." So
Yeah, perfect.
I always
Mhm.
get a kick out of that. So, I mean, I think it's very important that all of us be open to new ideas.
I think that's massively important. So I was actually thinking earlier when you said about you having ideas and it was getting rejected. I actually had the same thing. I don't know if you know about AMP kinase, AMPK.
Oh,
So
sure.
when AMPK first came along, getting activated during exercise and muscle and things like that, it was all like, oh, AMPK is increasing glucose uptake and fat oxidation, and it's like, well, I was like straight away, hang on, they don't go hand in hand, because as you increase intensity, you'll increase more glucose use, glycogen use, but your fat use will go up and then it'll go down. And then
Yeah.
same after training, that after training you'll burn more fat but less glucose and glycogen. So I did all these studies, but I had all this trouble getting accepted because it was going against this dogma. So same
Yes.
sort of thing, yeah. So people have to keep an open mind, and yeah,
You know, it's not just Glenn, as you know, in looking at presidential elections and stuff in the United States, it's not just science. We have to keep an open mind about all sorts of things.
oh, yeah, sorry. The main, yes, and then the main thing, presidential elections. Okay, let's not go into that, especially as we have an international
Oh,
audience.
that's
Although
all
we are
now.
all affected by that. Yeah, it was when I was finding that AMPK didn't regulate glucose uptake or fat oxidation. That's when things became difficult to publish. But thankfully, more people have shown that now as well. Okay, so we've touched on atrial fibrillation, yeah, but I wanted to, and then we want to talk obviously about other things like coronary artery calcium and things like that. But I wanted to just, I don't know, get a clearer idea. So, you've mentioned, and also Andre and Ben Levine, that endurance athletes live longer, and you're saying, maybe it is a form of endurance athletes, for example, live longer, and maybe there's a genetic potential there that they were already going to live longer anyway, sort of thing. I just wonder if we could talk a bit more about that. So this thing about, do we know for sure that the endurance exercise increases the atrial fibrillation rates? I think it sounds like we do. But what are the reasons that they're living longer? So there's potentially the genetics, but can you expand on that a little bit?
So let me hit on 2 points. One is what I'm saying is that I think there's probably a contribution to longevity from genetics. Okay.
Yes.
It may be a contribution to training, which leads to more longevity from genetics. So I'm
Yes.
not
Okay.
undermining the fact that exercise is good for you. I don't want to do
Yes.
that
Yes.
at
Yes.
all because
Yeah.
it's
I didn't
just
mean to say that either. Sorry. Yep.
it's okay.
Mm.
But I do think that sometimes the people, especially the people that are very, very good and they want to do a ton of work, they want training, they want to do that ton of work training because I think it's necessarily increasing their longevity. I'm not
Mm.
sure it is. It's doing some. Now, the second thing is it proven that atrial fibrillation is more frequent in athletes? Now, proof in medicine, as you
Yeah.
know, requires taking a bunch of people and training them all their life to seeing what happened,
Yeah.
taking a bunch of people who are somehow randomly assigned, not training them, and see at the end who got
Mm.
more atrial fibrillation. So is there absolute proof? No. Is there highly suggestive evidence that I can make a good story about? Yes. What do I think? I think atrial fibrillation is more common in endurance athletes. Why? Because there are a bunch of studies that show that after having tried, and it makes physiologic sense because of the bigger size
Bigger
of the left.
hearts.
So
And,
that's where
and
we are. But if you want to say, how can you say that, Thompson? It's not absolutely proven. I would say you are right. It's not absolutely proven. Here's the reasons I'm saying it.
okay, now is there a cutoff point? And again, I'm sure it's grey, and Andre talked about this a bit as well, of how many hours a week where it becomes, you think, increased risk of atrial fibrillation. And I'm sure it's volume and intensity interacting as well.
I don't know of that. I don't know of a cutoff point because I think it's going to depend on a lot of things. I think it's going to depend on your other risk factors for atrial fibrillation. Like atrial fibrillation goes up with alcohol, it goes up with blood pressure, it goes up with body weight. So it's going to depend on other things. It's going to depend on your genetics. There are some people who have a familial tendency to atrial fibrillation. Now, those are kind of obvious genes, but there are probably very small genes. So it's not possible to say what the break point is, if we could use that term. And there's one other thing. Remember, I'm not saying that everybody that's an endurance athlete gets this. So it's hard to study it. But I must admit, a lot of endurance athletes get it. And, I'm personally pretty convinced that lifelong or a lot of exercise training increases the risk of atrial fibrillation.
And what are the prevalence? So if you looked at all the Olympic marathoners, for example, and 10K runners, for example, do you have a rough idea of that? If you looked at every Olympic, since the 1950s or whatever, what percentage?
Haven't done it. Sounds like a good study. It sounds like a good study to do, to contact a bunch of people. Barry Marin, who's a well-known cardiologist, and I looked at a few years back, we looked at sub 4-minute milers and what happened to them. They lived longer than the people in their country when you compared them to the people in their country. But I think it would be a great study to look at, Olympic athletes and just get an incidence figure as to how frequent it is. Atrial fibrillation is incredibly common. Someplace I've heard that, well, it's just very common. It's a common disease.
The other thing is atrial fibrillation itself is not necessarily, life-threatening, etc. It, as you said, it can increase the strokes. The other thing I was thinking about was, my feeling would be that people that are fitter, I don't know about if they were fitter earlier and then stopped, but people that are fitter are more likely to survive things as well, right? So if they get a stroke, are they more likely to survive as well?
I don't know the answer to that, to tell you the truth. They're less likely to get strokes than other people with atrial fibrillation. Fit people are less likely to get strokes than other people with atrial fibrillation.
That's interesting.
But I always say to patients who argue with me that they don't want to be a blood thinner, I say, one stroke can ruin your whole day, especially if it's yours.
Absolutely.
So stroke is not a joke. So
okay.
There's another phrase I use all the time. Stroke is no joke. So atrial fibrillation is something that athletes should not be worried about, because the risk of, if you're in atrial fibrillation, the risk of having a stroke is 1.6%. It goes up 1.6% per year every time you have an additional risk factor. So if you have high blood pressure, if you have diabetes, these adds on. But the nice thing about taking a blood thinner is it takes your risk back to baseline, just like the rest of the population.
Oh, really? Wow.
Almost back to the rest of the population. Yeah.
And you're saying also that athletes that have atrial fibrillation are less likely to have a stroke as well,
Yeah.
you said.
They're less, now, did I say that? They're less, yes, I believe they're less likely to have a stroke. No, yeah. You asked about survival. I do think I can see the graph with the less likely to have a stroke. But, I honestly look for excuses to treat both my athletes and other patients with blood thinners, unless they have a real strong contraindication. Because the thing about strokes with atrial fibrillation is they tend to be big, because the left atrium and the area that the strokes come out can hold a lot of clot.
Okay. Now I'm interested when you say, because I know we're going to talk about statins lately, and there was a thing where someone was saying, you should put statins in the drinking water. So I want to talk to you about that. So I want to talk about the statin thing. But it also sounds almost similar. Are you suggesting that most people could benefit from blood thinners, even if you don't have
if you've got atrial fibrillation? I don't think people, blood thinners make you bleed. But so you don't.
Yeah, sorry, that was stupid. Yeah.
I mean, but if you've got atrial fibrillation, there's some people that probably don't need a blood thinner. But I look for an excuse to put patients with atrial fibrillation on blood thinners, because a stroke is a devastating thing.
Because, there was a thing for a while there. So Bill Fink, because as I said, I did my master's with David Costill, and Bill Fink was his man in the lab for many, 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 many years, and he just celebrated his 90th birthday. Anyway, what's my point? Oh, yeah. So way back then, when I was there in 1989 to 1991, Bill Fink was taking his daily aspirin, So that's why I was saying about everyone taking a blood thinner. Is that, my feeling is that's been shown not to be.
A little bit of a difference there, a little bit of a difference, because when we're talking about aspirin, we're talking about something that inhibits platelet function. Platelets are those little tiny particles that float around in your blood, and they stop bleeding when you cut yourself on the skin, for example. Aspirin tends to reduce recurrent heart events in people who have had a heart event. Blood thinners, anticoagulants, are different. They're things like Coumadin, which is the old drug. And blood thinners reduce the chance of that if you have a blood clot in the leg, that it will go to the lungs and give you a pulmonary embolus. Blood thinners reduce the chance that you get a stroke from atrial fibrillation. So it's a little bit of a different deal.
Different. Okay.
Now, the aspirin thing, aspirin has been shown repetitively to help prevent events in people who have known heart disease. The use of aspirin in the general healthy population is not presently recommended by everybody. But the issue is that when you look at the studies, aspirin increases bleeding risk about 10 or 11%. It reduces the risk of heart attacks by about, almost the same. So that people say the risk is the same. But I've always thought that a stroke, I always say, look, as long as there's blood in the blood bank, I'm not that worried about your bleeding unless you bleed in the brain. I am worried about your heart attack. So now this is Paul Thompson speaking. This is not some large governing body, but if there's a good reason to put somebody on an aspirin, I will do it.
When you're saying bleeding, you mean gastric bleeding, yeah?
Gastric bleeding or just other places, but yeah.
Really? I didn't realize that.
Yeah.
Okay, so you're saying you'd be, if you've got 11% greater chance of bleeding in the gut or some other places versus 11% chance of having less heart disease, you'd go for that.
Right. And what I'm really saying is get a doctor or a physician that you trust and go by what they tell you. It's always great to look it up and try to make your own decisions. But, what is the old saying that he who takes care of himself has a fool for a doctor or something like that?
It's a good one. I don't know exactly, but it sounds good.
You
Sounds
want
close.
to get somebody to trust in, because this stuff it's not simple. Now I love podcasts like this because it gives people knowledge to help make their decisions and to ask the right questions with doctors. But most of these things can't be decided on just a simple quote.
Exactly. And I have them down the bottom of my notes for the podcast, not medical advice. So it might point people in the right direction or give them some ideas, but they need to see their professional. Okay, now the other one is the coronary artery calcium effects of exercise. And so we had a good chat about that again with Andre and Ben Levine. And I think the takeaway was, well, maybe you should just talk about it, but it seemed like at any coronary artery calcium score, being fitter is protective anyway. But do you want to just give us some background on that?
Okay, so let me give you the spiel on coronary artery calcification. First of all, the calcification of the coronary arteries is both a sign that there's cholesterol deposits there, but it's also a healing, because the blood vessels tend to heal, injured lining by calcifying it. It makes it more stable. So one. Number two, we know statins reduce the risk of heart disease, but they increase coronary calcification. How can that be? The statins probably assist in healing. So one of the first things I do when a runner or an endurance athlete or a triathlete comes to me with a high coronary calcification score, and if the score is high, that means they've had a lot of atherosclerosis, is I reassure them, look, this is a healing mechanism. Distance runners seem to get a lot more coronary calcification than we would expect by their risk factors. There's no evidence that they do worse from that coronary calcification. And like you've said, and I'm sure Andre and Ben said, in general, that the endurance athletes and even those with high coronary calcifications do better and live longer. So what do I do about it? it is a sign that there's something going on in the arteries. And we and others, with my friends in the Netherlands, have shown that it's not just coronary calcification healing, but there's also other cholesterol deposited in the arteries. Nobody knows why athletes seem to get more coronary calcification, but let me give you my theory. I go back to this big heart thing. Now, where do you put cholesterol? Where do you deposit cholesterol? You deposit cholesterol in arteries where there's turbulence, where there's bending and twisting. So you get cholesterol deposited in the neck arteries because they go up there and they take a bend. You get cholesterol deposited right beneath the belly button because the aorta bifurcates. You get cholesterol in the femoral arteries because you and I are both sitting. That means our arteries have to make an acute right angle turbulence. Think about a river. If you see a river that's flowing fast, there are some parts of the river that are going very fast. For example, the part of the river that goes around the Big Bend, the outer part of the river, the water has to move faster. The water that comes on the inner part of the bend, it doesn't move as fast. So when there's twisting and turning, there's turbulence, there's some injury, and you tend to deposit cholesterol there. Now, think about the heart. Here are your coronary arteries. We call them coronaries because they look like a crown, the coronation arteries. Every time your heart beats, those coronary arteries have to twist. They're on the outside of the heart. They're going along for the ride. They're getting twisted and turned. So we think that, number one, people tend to get cholesterol in their heart arteries before others places because of twisting and turning. And if your heart is big because you've done a lot of training, then your heart is like a big accordion. When it's not beating, it's wider, it's more stretched out. When it beats, it squeezes down more. So we think, this is me. When I say we, I think Paul Thompson and Paul Thompson Jr. and me, that it's the excursion and squeezing of the artery that creates turbulence, which causes atherosclerosis. How are we going to prove it? I don't have the foggiest idea, but it's just a theory.
Wow. Okay. How could you prove that?
I'll tell you one interesting study that was done way back in the 1990s by a woman named Polly Beer at the University of Chicago. She took monkeys and she ablated their heart rate. So they ablated their heartbeat. And then she paced them at various rates. And the slower she paced the monkeys, the less atherosclerosis they got in their neck and the less atherosclerosis they got in their heart. And she thought that by reducing the number of beats, she reduced the amount of turbulence. So there's all sorts of evidence that turbulence, is a contributor to the coronary arteries. Now, what you should be saying to me, Glenn, is, hey, wait a minute.
Endurance athletes have slow heart rates.
Slow heart rates.
Exactly.
So how can that happen in them? I don't know. I think it's just maybe why you have to do a lot of exercise and get your heart rate up for a long period of time. But I don't know. But we don't know. First of all, we're not absolutely sure that athletes have more atherosclerosis. We're not absolutely sure that they have more calcification, but it looks and why do I say that not absolutely sure thing? Because of the randomized double-blind, control group. But all the data suggests that they get more coronary calcium and they get more atherosclerosis. Now, this is primarily men. There aren't many studies in women. And, women are lucky that atherosclerosis is delayed in women. So it may take longer to find this out.
Wow. Okay. There's a lot of interesting stuff there. So, yeah, I was thinking, when you said the heart gets more atherosclerosis, is it partly because it's going the whole time as well?
It could be that it creates turbulence more frequently. So every beat is a little bit of turbulence. Now, you get symptoms from your heart. If you have the same degree of narrowing in your heart and your legs, you'll feel it much. I'm not totally sure of this. I think you'll feel it much more in your heart. Yeah, of course you will. You'll feel it much more in your heart because when you exercise, your heart rate really goes up. If you go walking, you don't make steps at 140 beats per minute, right? 140 steps per minute. That's be unusual. So you tend to get symptoms of the heart more before other places with similar degrees of atherosclerosis because the heart is working at least I hope it is, every second.
Yeah, I remember someone asked me, a newspaper asked me to do, there was that Melbourne Marathon in Australia was coming up, and they wanted to have like a daily sort of story about it leading up to it. And they interviewed me, and I talked about, warming up and various things. And they somehow said, Professor Glenn McConell says that you have to,
Goodbye. My wife is leaving.
oh, bye-bye. Um,
Not for good, we hope, but she's leaving. She's
yeah.
gone off to Maine. We have a
Oh,
place in
she's
Maine.
leaving. I thought she was just going to the shops or something. Well, do you want to say a proper goodbye to her?
I had no idea. All right, it's all right.
All right. Anyway, so I spoke about this stuff, and then they wrote on page 3 of the newspaper, Professor Glenn McConnell says you have to warm up the heart before you exercise. Because it was like, what? The heart's going the whole time. So that was not a good look, and it was kind of embarrassing when it had grants. People about to review grants. It's like, this guy thinks you're warming up the
Yeah.
heart. Yeah, so I'm just thinking more about this turbulence in the heart and the athletes having a slower heart rate. So I guess remember for a while people would say something like, "Oh, you've only got a certain number of heartbeats. Once you've reached those, you'll die," which sounds
Yeah.
ridiculous. I'm wondering about because the endurance athlete. So just to remind people, if they don't know, that on average we tend to say that a person's heartbeat at rest is about 70, 72 or something, and then decent endurance. Like my resting heart rate used to be 36 or whatever. I know people have had 28 or something. So just say you've been running a lot and you've got a big left ventricle. So it's pumping a lot of blood at rest. So it doesn't have to pump as often, just so people can understand that. So then your
That's
resting
right.
heart rate would be 36.
Oh,
So it's half. So you're pumping double per beat because you still have the same cardiac output needs at rest. And then you go and exercise, even if you're running 2-3 hours a day, your heart rate's obviously higher while you're exercising. But have you ever done the calculations? I think you still have less beats per day.
yes. I
Is
have
that
done
right?
the calculations a long time ago. So if you run like 2 hours a day and you get your heart rate during that time at 140, 150, which would be a reasonable number, and you drop your heart rate from 70 to let's say 40, it doesn't take very many hours till
No.
you've got fewer beats. So
Yes.
that's the thing to argue with. And I tell you this idea about coronary atherosclerosis and why it happens is pure speculation on my part. I use it partly to explain to people why cholesterol tends to deposit. Because cholesterol tends to deposit in places of turbulence
Areas of
and
turbulence. Mm-hmm.
where there's change in flow and changes in flow direction, stuff like that.
But your argument could still also hold though, because the amount of turbulence at rest, I'm sure, is much less than when you're exercising, when you've got all this pumping and relaxing going on. So you've got a whole lot of turbulence going on
Yep.
for, I don't know, 2 hours a day, which an untrained person wouldn't have.
Yep.
Yeah, that's
So,
interesting.
it's interesting that we're finding all these things. And what my speculation partly is that, for example, I'm a child and ran competitively in the 60s and 70s. And so first of all, we haven't seen people that have continued exercising all their life the way we do now because it wasn't something you did. And so, I think we're going to learn a lot about what happens with lifelong endurance exercise because we have a lot of people that are doing it now.
Yes. So you're saying that the people that do a lot of endurance exercise have more coronary artery calcification, and the way you measure that is to actually do a scan of the
Yep.
calcium. Is it right? Yes. Now, we talked a lot about this in the previous podcast, and you touched on it as well. I just want to make sure that we're all on the same page. So even though, so I know Ben Levine was talking about this, even though there's more calcium, more calcification in the coronary arteries, that's considered stable. The plaque is more stable, and what you don't want is an unstable plaque, correct? So that you can
That's right.
actually have a higher coronary artery calcium slash calcification, but have a lower risk of a heart attack. Did you want to just take us through that?
You do. Now Ben and I disagree a little bit on this. We disagree a little bit on this because if you look at the people with lots, and I've got to get this straight in my mind, if you look at the people with a lot of coronary calcification, who are, even though they're endurance athletes, they appear when I look at his data, they appear to have more events than the people who don't have the calcium. So the calcium does convey. It's not a benign. I don't want people to think it's a benign condition.
Okay. Mm-hmm.
It's not as bad as if they had both calcium and weren't active, calcium
Yes.
and weren't fit. But I don't view it as a total. I don't think it's something that people should obsess about, get all sorts of worried about. I don't think we have to lock the windows on them. But I think reassurance is appropriate, but I don't think it's totally benign. And that's why I'm sure Ben and Andre said the same thing. I tend to treat their cholesterol levels and try to reduce their risk of heart disease as much as possible to keep those plaques stabilized.
Yes. And is it correct as well? I'm sure it is. Andre said it, that at any a coronary artery calcium level, the fitter person has less risk. So if you've got the same coronary artery calcification, an untrained and a trained person, the trained
Agree with
person
that.
is much lower
Yes.
risk. Oh, is it much? Would you say much lower? Yeah, much lower.
I think it's much lower risk. Yeah, much
All
lower
right.
risk.
And the other thing with Andre, I just want to make, because I want to start talking about statins and some other things you've done as well. The other thing I just want to make sure people are clear on, because Andre said over and over, but I'm not saying, is because people can get caught up on this. Oh, exercise people have higher atrial fibrillation. Exercise people have higher coronary artery calcification. Therefore, I shouldn't exercise. So can we just take a big shot at saying how important exercise is and, despite these things?
Well, if we had one public health intervention, smoking aside, since it's gone down so much, but if we had one public health intervention that would do the most for a population, it's to exercise, to get the population doing things and exercising. Because exercising just has tons of benefits. Just about every epidemiologic study you look at, those people who are active, steps, no matter how you measure it, steps per day, fitness, whatever, they live longer and they survive better. How much of that is the exercise? How much is that because they are certain people that want to exercise? But there's simply no doubt about the fact that exercise reduces the risk of these cardiovascular events. So, as we've talked about, there's probably a genetic component to your wanting to be a golden, an Irish setter and run around all the time. There's probably a genetic component to that, but it does make you healthier and probably makes you live longer.
Yeah, it's an interesting. I think about it when you mentioned the Irish setter. I think you said it is if you heard about those high capacity running rats and the low capacity running rats. Have you heard about those studies?
It's an amazing study. So for people out there who don't know it, what happened is a group of people, I can't remember the originators, but they took and they saw how fast rats could run, and they bred the best rats with the best rats and the worst rats with the worst rats. And over time, they found that not only were the best rats remarkably better, but they had remarkably better other risk factors. So this being fit affected your other risk factors for heart disease. Those are, I've forgotten about those studies. I don't hear much about them anymore, but they
Steve
were
Breton, I think they're up to like, I don't know how many. Yeah, so the important thing as well is these rats, they didn't train them. They just took them naturally, the naturally good runners, the naturally bad runners, and just bred the bad runners with the bad runners and the good runners with the good runners. And as you said, they actually have less heart disease risk and things as well. So that's pretty amazing. Now, yes. Now, what I wanted to do is just, I think if someone's at home and they go, "Oh, I've got a high coronary artery calcification score, or I've got atrial fibrillation, what should I be doing? Should I exercise or not?" I'm assuming you say the answer is yes, but so if you've got atrial fibrillation, should you exercise? If you've got high coronary artery calcium, should you exercise? If you've got both, should you exercise?
So my answer is that you should, but you really should check in with somebody, a professional that knows about this, whom you trust, and make decisions with them. I almost never restrict exercise in somebody who likes to exercise. And I'll tell you why. I don't think that these exercises are manic depressives. Like, I don't think they have these peaks and these terrible valleys, but they're people who find that have up and down downs to their days. And they find that the exercise helps them eliminate the down days. So they get addicted to exercise, because if they don't exercise, they just don't feel as good. They don't feel like they've accomplished something. I don't know what it is, but it's, and there's psychologists have looked at this and they've examined that there is a type of exercise addiction, whereas if you don't do it, you don't feel as good. So what do? I suggest that people do their exercise. It's just that, you know, most people, as I say to them, are not going to Paris for free. So do you have to push quite so hard? You know, can you enjoy it and not think you have to do 3 hours a day, or not think you have to do intervals all the time? And it's especially until we get things under control, until we get your atrial fibrillation in control, until we get your cholesterol level down and that sort of stuff.
All right. So what about some people that exercise like crazy? Because I've started asking myself, because I used to be a competitive distance runner and all this, but you know, and I've got that mentality to exercise hard, right? And it's actually, as I've got older, I've noticed that I get injuries and all that. So I'm mainly riding. And if I'm riding indoors, you know, I've got this, you know, I can race people around the world and all that. I'm live nowadays on indoors. You know, and I sometimes think I don't actually feel like flogging myself, you know, like intervals, racing. I just feel like exercising slow, and it's good for my health. You know, what do you say to, you know, do you know what I mean? Like you think, why am I going hard? And the question is, I guess, is there any rationale to actually go hard? You know, like if you're not racing, this is kind of treating you like my
All goes
psychologist or
back to
something.
goals. What are your goals? If your
Exactly.
goals are to race, you got to train hard.
Exactly.
If your goals are to live longer, you don't have to train so hard. Now, you don't want to be on there, you know, 10 revolutions per minute on the, you know,
No.
10 hours per minute on the bike, obviously, but you don't have to, you know, you don't have to push yourself so hard. So my advice is have fun, you know, enjoy yourself. I enjoy, you know, occasional hard hill. Doesn't mean I go up and down hard hills. I want to see the countryside and think about things riding around. So, you know, I think you don't want to do nothing out there, but I don't think you have to push yourself unless you want to race. And then, like, if you're going to ride a 100-mile, you know, race someplace, you need to train for it.
Exactly. Yeah. I don't know why I just decided I wanted to get a free psychology lesson from consultation from you, my a cardiologist.
I'm the cardiologist. The psychology I totally make up, but
Well, actually, I actually get it now because I go to my
self-observation.
yes, actually get it. Yes, I actually get it now because I went to my general practitioner at one stage and he said most people come in just to have a chat. So I think I've just used you for that reason rather than, you know, having an illness. Okay, now I wanted to ask you something. I saw a paper of yours here, dose response association between moderate to vigorous physical activity and incident morbidity and mortality. All right. Now, what you found there was there's a curvilinear relationship. So the more moderate to vigorous exercise you did, if you didn't have heart disease, it sort of improved and then it plateaued out. But the people with coronary vascular disease, coronary heart disease, it was linear. Do you want to just tell us about that? I found that really interesting.
Well, I'm not sure I can give you much more insight into that since I don't remember exactly all the details of the paper. So let me make
that's all right.
some
They should be
general.
encouraged that more is better, the people with coronary vascular disease, but you're saying the people that didn't have, so the people that had, the healthy people and the people with coronary vascular disease risk factors, it was sort of, it went up and then it plateaued out, but the ones with heart disease, it kept going up.
It's interesting. When was it?
You got too many papers. This year.
All right, it was probably done with
This is
my
the
friend.
cohort from the Netherlands, 142,000.
This was my group from the Netherlands. You know what? This is terrible. I hope it's not senility, but I don't remember the details of that paper any longer.
That's
You know
right.
what? You go through it, you do the data, you help them write it,
You got
and
too many
then
papers. I'd take that as a badge of honor. That's great. So what else? So we talked about.
I guess I can make some general statements from it all. In general, I don't know this paper in general. In general, people get the most bang with going from no exercise to a little bit. Now, what do I mean? You go
Yeah,
from no
makes
to a
sense.
little bit, you go from here to here, you get a big plunge. You do the same amount more, you get less of a plunge, and it kind of flattens out. So in the healthy population, you generally get the most from doing relatively little. That we're talking about survival and heart attacks and stuff like that. Just as we talked about,
That makes
you
sense.
can't do that if you're going to train. Now, with people with heart disease, if I remember, there was more of a direct, the more you did, the more you got out of it. Now, one of
Yes,
the problems for that, that's because the people with heart disease weren't doing much in the beginning.
exactly. Mm-hmm.
Okay. So, you get, when you have heart disease, if you're generally not doing much, so you've got a lot farther place to go before you start to flatten out. So you get your big
That makes
decrease
a lot of sense.
down because you haven't done so much activity. That's if I recall that
That
that was the
that makes sense. Yeah. So it's like the classic thing. If you get someone that's got a pretty high VO2 max that's doing quite a lot of exercise, if you train them more, they'll go up. That it won't go up as much and it'll plateau earlier. But if you're doing nothing, your VO2 max has got more room to move. Now you've also got another one here. Steps may count for more than just cardiac risk. That's an editorial you
That's an
put out.
interesting paper. That's a very interesting paper. Now, this is, when there is something that we use in the intensive care unit to help the heart. It's called the balloon counterpulsator. Believe it or not, if someone is really sick and dying, we go into their femoral artery and we put in this tube that has a balloon on the end of it. And when the heart beats, the balloon collapses. The air is sucked out of the balloon. But when the heart is not beating, we expand the balloon. Okay. By blowing up the balloon, it pushes our blood backwards into those arteries that feel the heart. Okay. Mm-hmm. It pushes blood up to the brain.
Sorry, where do you put the balloon?
You put it right it goes up and it goes into the aorta and it winds up right about here.
No, so yeah, I'm thinking, so in the aorta, is that what it is? That's the bit I missed, sorry.
It's actually in the aorta.
Oh,
in the aorta.
That's pretty funny. Oh, that's pretty heavy.
Yeah. You don't want one of these. This means that
you're in a bad way.
You should have made your will. Okay.
Yeah.
You got some troubles coming. Ben Levine and some of his friends, an anesthesiologist from Stanford, looked at what happened to the heart when you stepped on a treadmill. And if you step and you can time that step with the relaxation period of the heart, exercise can simulate blood being pushed backwards, just like that intra-aortic balloon. Now, this was a very small study, only 10 patients. I reviewed the article for circulation. In fact, I was the guest editor. That's Guest, not Guess.
Not the guest. Yeah, the guest.
But it was a small, they occasionally asked someone to come in circulation, which is a very prestigious journal, to review one of these articles. I was asked to review that. It actually happened to come out of Ben Levine's group, but it was just interesting how exercise could mimic this thing that we do to keep people alive when they're very sick. That was very interesting. So for that is of almost no utility to your audience, but I find it fascinating.
I was thinking it could maybe you could mimic that with cycling if you went into particular cadence. I was wondering if people might want to mimic that. And that actually reminded me as well of your theory about turbulence causing atherosclerosis.
Exactly.
Wonder if they looked at cyclists, because they're spinning so much. So if they looked at their femoral artery compared to non-cyclists, because they've got a lot more turbulence, and if they've got more atherosclerosis at that point.
Yeah, I actually don't know about that, but there are cyclists. There's a well-known narrowing of the femoral artery that actually occur in cyclists. It's a problem. So if you're a cyclist out there and you're getting cramping in your legs or pain in your legs, there's a condition in which you get fibrosis of the femoral artery because of its bend. So that's an issue. But I don't know if it's been looked at. There are some, I don't think it's been looked at.
Yeah, and whether another way you could do it is look at cyclists that tend to ride at a low cadence, compared to ones that go at a high cadence. Anyway, can the heart get an overuse sports injury? your paper 2023. I guess that's sort of stuff we've talked about.
Yep. So that's a paper that was done in one of, a lot of these journals, the New England Journal of Medicine has some spin-offs, and that was published in one of the New England Journal of Medicine spin-offs. And what we talked about in that paper is we talked about the fact that during exercise, you do release enzymes from the heart. You do release some of the same enzymes that are seen with a heart attack, but it's not a heart attack. It just complicates the heart as well. We talked about the fact that the right ventricle, remember we talked about it getting bigger, that the right ventricle can look fatigued during exercise, and you can also get a little of scarring. You can get a little scarring in the right ventricle. Actually, here's the wall between the two sides of the heart. So here's the right ventricle. And where you get the scarring is oftentimes right where the right ventricle inserts into that wall. So what we think is as the heart enlarges, it puts a stress on those attachment points. So you can get troponin release, this enzyme release. You can get enlargement of the right ventricle. You can get some scarring of the right ventricle. You can get atrial fibrillation. You can get this coronary calcification. And also, the people at Mass General have shown that the aorta, the big blood vessel that comes out of the body, tends to be larger in lifelong endurance athletes as well. And it's very interesting. In many of these studies, the better the athlete you were, the more likely you are to have a problem. For example, the better athletes get atrial fibrillation. Now, why is that? Because if you're a good athlete, you got a good pump. If you got a good pump, you got a big heart. The aorta, why would it be enlarged? Because if you're an athlete, you got a big pump. You got to pump that blood someplace. It goes into the aorta. So for me, I think a lot of these things may be related to heart size, but it's going to take a while. I don't know if we'll ever know for sure.
Okay, that's interesting. And it makes me also think, and I vaguely touched on it earlier, it was intensity versus volume, I guess, as well. And I see you've got a paper in 2023, exercise volume versus intensity in the progression of coronary atherosclerosis in middle-aged and older athletes, finding from the Mark II study. Did you want to just tell us a bit about that?
Study looking at runners in the Netherlands, athletes in the Netherlands, a couple hundred runners in the Netherlands, and it really did look like intensity was the biggest driver. And if you summarize the literature, which some of my friends have done from the Netherlands, including the group led by Thijs Ijsvogels, if you summarize the literature, it looks like intensity is the biggest driver of this coronary calcification thing. That's the way it looks.
Yeah, so I think when I was stumbling around saying what should I do and why am I doing this, I was actually thinking about that when I saw that your paper, when I was getting ready, because I was thinking, okay, so why push yourself, if you're not training for something. Now, how would you put that together? So if you just want the health benefits, are you better off just doing lower intensity exercise rather than high intensity?
I think if you just want the health benefits, you're better off doing the lower intensity stuff. But if you want to compete or you enjoy it or you feel better about yourself doing some intensity, do some intensity. I don't think it's so terribly dangerous. I mean, these are findings that they're true, and they have some sense. But I don't think where we are now, it should have people change what they want to do.
Keep it simple as well, yeah.
Keep it simple. Exercise is good for you in general. Tons of exercise may have effects that aren't so good for you, but it doesn't negate the effect of the exercise. And would I tell somebody that likes to do a lot of exercise to stop it? No, but I would ask them why. Is it really necessary for your enjoyment? And because if you're doing it because you think it's the best thing ever for your health, you may not be totally correct.
Yeah, and we don't want it to make to be too complicated, because then people go, hang on, should I be doing intense? Should I do it easy? Should I do it? Just go out and do it, right? But one thing I am reminded of those is, I think if Ben Levine was listening, he'd say, oh, hang on, because he did say in the chat with me that walking, so we talked about steps and its protective, reduces your mortality risk, but he was saying also that just walking, unless you're really, really unfit, but if you're just the average person, walking is probably not a big enough stimulus to increase your left ventricle size, increase your heart size, etc. Is that fair to say?
That's fair. So I'm going to speak for him, although I didn't hear exactly, so I don't want to say, but we're talking about lots of different things. Walking is great exercise because the number of steps per day you do, in one of the studies we did with the folks from the Netherlands, it looked like about 8,300 steps per day were a great number. So close to that 10,000. Those number of steps are associated with less risk of heart disease. Now, nobody said that those number of steps are going to get you to the Olympics or, but they help for health. So now, would that amount of stepping do a big deal for your oxygen uptake? Probably not. Probably won't change things that much. And since it doesn't change things that much for your oxygen uptake, we know it's probably not making your heart too bigger. So if you said to me, okay, Thompson, look, knowing all you know about exercise, the danger of exercise, and I'm talking something we haven't talked about, but sudden death, like we've always shown that sudden death is more common during exercise. So when you exercise, your risk goes up, then it comes down. So to all of those things, what would you say? I would say, first of all, do what you enjoy. The exercise you enjoy is the most important thing. I think among the best exercises for health is vigorous walking. About 8,000 steps a day would be great for your health, would help with your weight, would help with your blood pressure. I didn't say 3 days a week. I said daily. I think you should walk an hour every day. And if you can't walk an hour every day, make it up on the weekends. But you should get about 7 hours of walking a day. Now, that's more than is generally recommended by the surgeon's guidelines. In the United States, the recommendation is 20 minutes of vigorous exercise per day, which is a reasonable recommendation.
Yep. But again, you'd say
I would recommend you go about 8,000 steps a day and you try to do it every day and you do it briskly.
Briskly. Yes. So I guess one thing there is doing the slow sort of walking, just doing the steps, you're going to be getting the sort of the metabolic benefits. So when you have an improvement in your cardiovascular risk, it may not be the heart itself. It may be just the metabolic, reducing your cholesterol, etc. But then when you do it more vigorously, you'll be getting the metabolic effects plus the benefits on the heart. Is that fair
There
to
you
say?
go.
Yep.
Yeah, I agree. Now, remember, having good exercise performance, having a good exercise capacity is associated with lower risk of heart disease. And why is that? Well, suppose you've got a good heart, a big, strong heart, makes you a good endurance athlete. If something happens to you, okay, you have a heart attack, you still got a bigger heart than most people ever would have. So I say if you're a great endurance athlete, your heart can, just like the Timex commercial from the 50s, take a licking and keep on ticking, right?
Okay.
So, there's a lot of benefits from being aerobically fit. You can take a COVID infection better, et cetera, et cetera. I'm not minimizing the benefits of high intensity training. But if we're talking about what's associated with deposits of cholesterol in the coronary arteries, it looks like intensity is the driver. Not the only driver, but the biggest driver.
Now, it reminded me, I managed to break my neck of femur, so the biggest bone in the body, in a bicycle crash. And they were amazed how well I recovered from the surgery and things like that. They said it must be because you're fit, right? But I was also lean and, whatever. I was wondering if you've picked up on that. I'm sure you have over your years and years of working with, heart patients, etc. Do you find that they recover a lot better? They cope with the surgery, they survive the surgery, they recover quicker. Do you see that clearly?
Absolutely, because they have a bigger reserve. If you can run a 5K, 10K, or whatever, you have a capacity above what you need to survive. That's your reserve capacity. And so, yeah, you get sick, you lose something, you still got plenty of capacity. If you get a pneumonia after your operation, not an uncommon thing, and you've got a big reserve capacity, you can survive it. You got a crummy reserve capacity, it may be checkout time for you.
Yeah, and indeed. And that's why, when did people start doing this? Probably in the 60s or something. When did they start actually exercising people before they had their heart operations? If they could, they'd try and get them fitter before the...
Pre-rehabilitation. pre-cardiac surgery rehabilitation. And it's probably an idea that's 30 years old or so. But getting people in shape before, and really you ought to, if you're out there, you ought to think about it for yourself. If you're going to have knee operation, well, get your quadriceps in the best shape you can get it with your knee pain. Totally understood. But because you'll be able to recover much quicker if your quad is strong. Now there's nothing that goes away like a quad. A quad goes away very fast when it's mobilized. I'm sure you've noticed it in yourself with your knee thing. But if you start with a bigger quad, you've got more space. And I'm sorry you broke your femur. That sounds like a terrible event.
That was really crap. I did not have big quads, believe me. Now, I'm going to go through a whole bunch. I feel like we've had do you feel like we've covered these sort of issues quite well? And then I've got other things, like people sent questions through on Twitter. And
sure. And you wanted to talk a little bit about statins, I think, didn't you?
Yes, absolutely.
Okay.
Yes.
So let me give you the spiel on statins. What's the biggest side effect of statins? You're going to live too long and you're going to outrun your money. Okay. So, you're going to get feeble and you're going to live so long that you wind up in a nursing home. Now, I'm partly joking, but statins have been shown repetitively to reduce the risk of heart attacks and heart disease over 5-year periods by about 30%. I do not think they ought to be in the water. Why don't I think they ought to be in the water? Because about 5% of people get some mild muscle aching, okay? We did a study in which I randomized 420 people to the highest dose of atorvastatin, 80 milligrams, or placebo. We followed them for 6 months. In the atorvastatin group, about 10% of them got muscle pain that went away, came back when we put them back on the medicine. In the placebo group, 5% of people got pain, came on with the placebo, went away when we stopped the placebo, came back. So we think about 5 people, 1 in 20 gets some mild muscle aching. Most people can put up with it. What about weakness? We've studied weakness in so many studies of statins. We've been unable to show that anybody really got that on average, people got weakness. We do think that statins affect skeletal muscle. If you exercise on a statin, you have more evidence of muscle injury, but the body adapts to this. If you need a statin because your cholesterol level is high and you're an athlete, I would encourage you to at least try it. You're probably not, like Mickey and the cereal, Life cereal. Try it. You might like it. You try the statin. It probably won't hurt you very much. And you'll there's no doubt about the fact that if you need it, you'll live longer. Runners have this sense that they're immune from heart disease, but like the studies we've talked about, you're not. If anything, you probably get more calcification and more coronary atherosclerosis from whatever reasons. So I'm a statin. I'm a big statin fan. I'm not saying that there aren't. There's very rarely, very rarely, people will actually develop antibodies against their own muscle from statins. It happens once in umpteen, very rare. So there are side effects, but they're very, 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 very rare. And I don't know a cardiologist my age who's not on a statin. They prevent strokes, they prevent heart attacks, they're good drugs. Now, look, I always tell people I'm a drug dealer, right? That's what
I saw
do.
that. It was on your papers. It was Confessions of a Drug Dealer.
Yeah, I use drugs because people want to do it all by good living diet. Well, a good strict diet will reduce your cholesterol level if you're careful about it. And depending on what you ate before, 8 to 20%. A statin, even at a low dose, will reduce your cholesterol level about 30%. So I don't view medicine as a morality play. Your arteries really don't care if you got there by good living or you got there by a drug. I don't care. If you want to do good living, great, do it. I really want you. I prefer you do good living. I really prefer you do it. But I don't prefer you wait 15 years until you get your heart attack and then you decide that good living wasn't enough. I think that's all. That's my take on it.
It is a tricky one, isn't it? Because I know I was a bit horrified the first time I heard an endocrinologist say that it happened to be a he, but it could be he or she, prescribes metformin to people with newly diagnosed people with diabetes before, because the idea generally was, try and get them to improve their diet, if needed, exercise, and then maybe metformin. He was saying, well, most people don't improve their diet and don't exercise, and then you just end up delaying giving them the metformin. So I just give them the metformin at the start, and I'm like, oh crap, it's just it's a tricky one.
I agree, because when you're waiting, your pancreas is actually getting tired. When you start to have borderline diabetes, believe it or not, you've already lost 50% of your insulin secreting capacity. And now the pancreas is working harder. So it loses. And so the longer you delay, metformin delays the onset of diabetes. Metformin is being studied, I don't know where these studies are, as an anti-aging drug. Metformin increases the number of mitochondria in your skeletal muscle, just like exercise. So what I got to admit, I had borderline numbers for my I'm on metformin, and it's a wonderful drug. There are, everybody can pick on the pharmaceutical companies all they want, but we as clinicians, I've been at this I graduated from medical school over 50 years ago, 1973. And boy, we have so much better drugs. I mean, we can really make a difference in people's lives. I never saw 95-year-old patients, never, all my life. Now my office is full of, people 85 and older because of they're living healthier, and also the medicines we have. I think waiting for people to fix themselves by good living alone is like that Samuel Beckett play, Waiting for Godot. The dude never showed. So I will wait, and I will go along with people because it is their body. But I can tell you, nothing cures statin avoidance like a heart attack.
Yes, that's true. There is actually some evidence that metformin can negate some of the benefits of endurance training. That's another story. We actually had a podcast on that earlier.
That would be a very interesting thing to see, because, I've heard of those studies. Obviously, I don't think you should, if you can, if you're an endurance athlete, obviously you can't control it by exercise alone. So don't put it off too long. And there are other things besides metformin. I mean, metformin was my go-to drug until we got these new SGLT2 inhibitors and GLP-1 agonists. We now have wonderful medicines to help people.
Now, as you said, sudden death, we didn't really talk about a whole bunch, but people sometimes use the argument, oh, Jim Fixx, who wrote the complete book of running, he died running, so therefore, running is no good for you or something. Do you want to talk about that a little bit, just sudden death and those sort of concepts?
So here's the studies. This is your overall death rate. This is your overall death rate. When you actually exercise, you go above the line. So your risk when you're actually exercising goes up, but then your risk goes down under the line. Overall, fit people have lower risk of sudden death and heart attacks. Perfect. But while you're actually doing it, your risk goes up. Now, why is that? Because just like I said, those twisting coronary arteries, your heart's beating harder. Those arteries are flexing more like, it's like a rubber hose. Your arteries, when they get cholesterol in them, is like a rubber hose that's been left out in the sun. It gets stiff. And so if you bend that rubber hose, what happens?
It's going to crack.
It's a crack. If you get a crack in your coronary artery, we call it a crack in the coronary plaque. It's like a cut in the skin. You bleed, and then your platelets clot it. If you get a crack in your coronary artery plaque, the platelets clump. That blocks the artery because it forms a blood clot. We talked about the aspirin preventing this. It forms a blood clot that blocks blood flow to the heart. So we call it a crack in the cholesterol plaque. And those cracks are more common during vigorous exercise.
All right. And now what about, I saw...
Message. You want to spend the next hour as safely as possible? Go to bed alone.
Alone, yeah.
If you want to, but that's not a fun way to spend the rest of your life. So exercise reduces your risk while you're actually doing it goes up. So pay attention to yourself. If you have new symptoms, you have chest discomfort or something's not right, don't think the exercise is a panacea. Talk to somebody whom you trust to get good medical care.
Great. Right. Now, I also read somewhere or heard somewhere lately that it's not that simple also that it's the percentage of the occlusion of the coronary artery that, because, my simplistic thing was if you're 99% occluded or you're 70% occluded is not as bad as 80% occluded, but it's not that simple. Is that right?
No, it's a little bit more complex. So we got to talk about a couple things. One is acute heart attack. A heart attack or sudden death is often, not always, caused by an acute occlusion. If the artery has grown narrowed over time, your body tends to adapt to that. So if your artery is narrowing down over time, your artery makes collateral arteries. So let's take an example. So I drive to work when I don't ride my bicycle on Route 91. So if I'm going Route 91 toward Hartford and I'm listening on the radio as I'm driving along and it says a tractor trailer truck has turned over and is blocking the artery at 36, if I hear about that early, I'm not late for work because I get off. I take a collateral artery into the city. But if I'm driving along and I just passed exit 35 and I hear a tractor trailer truck just turned over at 36, the highway stopped, I'm stuck. That's the difference between a heart attack, the tractor trailer truck turned over, I didn't have time to get a collateral artery, versus it narrowing down. As the arteries narrow more than 70%, you tend to have symptoms. Now, what are the symptoms? People are always told to look for chest pain, but it's often a chest discomfort. It's not really pain, it's discomfort. Okay. So they get shortness of breath that's unexpected. So the point is just pay attention to yourself. Now, I don't want to make people hypochondriacs, but some runners have this sense that nothing's ever going to happen to them. Well, I hope you're right.
Okay. Now, this is fantastic. I'm really enjoying this. Now I've got a bunch of different bits and pieces, some Twitter questions, some other bits and pieces. Now, one of paper, I couldn't help noticing you've got a paper here. It's Andre Gerche, who's been on the podcast, Aaron Baggish, who I haven't had on the podcast, but I've seen mentioned all over the place, Ben Levine, who's been on the podcast, and now you, who's been on the podcast. Fears of a big bang for rugby players, urgent validation required. So I was born in New Zealand, so I'm still a big All Blacks fan with the rugby, and it's not talk about the World Cup, which is, anyway, that happened last year. So what are you thinking, what's going on there?
So this was an editorial that Andre Gerche organized and we wrote together. But it was one of the first studies showing that the aorta, the big blood vessel that comes out of the heart, is bigger in rugby players. They looked at a bunch of largely retired rugby players and showed that their aorta was much bigger. Now, why are you worried about the aorta being much bigger? Because if the aorta gets bigger and bigger and bigger, it could actually burst or rupture. It's like a balloon. You blow a balloon up too far, there's a problem. It could pop. So that was the concern. Now, to my knowledge, there is the Australian rugby study. There's one study out of the group at Mass General in Boston led by a really good young person named Tim Churchill. And he showed that the aorta was bigger in rowers and runners. And there's another study with the National Football League showing that these football players had bigger aortas. The one that impresses me the most is the endurance athletes, because I'm interested in endurance athletes. But also that study out of Mass General by Tim Churchill showed that the better you were as an athlete, if you were an elite rower or you were a two-something-or-other runner, you had bigger aortas. And it all goes back to that thing.
Size of the heart. Yeah, exactly.
There you go. So I think, that I don't want to
just normal adaptation.
I don't want to push it too far, but it looks like these athletes have bigger aortas. Now, the thing we need to follow is, do they continue getting bigger? And is a big aorta in an athlete the same thing as a big aorta in somebody else? We don't know that yet, but it's interesting.
Yeah, so as you say,
it's fun for me, Glenn, to be at this stage of my career, semi-retired here. and still finding things that are interesting. And that's one of the, as you know, you probably think the same way in terms of being an exercise science and exercise physiology. It really is quite interesting, especially if you're,
Oh yeah.
have some interest in athletics.
Well, all I'm doing at the moment is the podcast. I don't know if I'm retired or not, but I took a package and anyway, it's the same here. Every talk almost we come up with questions like, oh, I should be great to do that study, even though it's not even I'm an exercise metabolism guy. So yeah, everything's just really interesting. Oh, I should race over there. Let's do this study together. Mm-hmm.
But I don't know what your experience is. I write this blog, as I talked about 500 rules of cardiology. I spend a lot of time on that. So
Yeah.
I don't know what you spend in the podcast, but it's often very surprising how much time these things require.
Yeah, well, I was pumping out. I did 77 podcasts in 78 weeks initially, and then I've slowed down. That was taking a lot of time organizing and editing and whatever else. Now, one thing we talked about before we started as well is you said, why don't you tell us how many meals a day you have?
Say it again.
Why don't you tell us how many meals a day you have?
Oh, well, I eat one meal a day. I got up to 100. So when I ran competitively, I weighed about 127, 130 pounds, and I'm 5'7". So I'm very thin boned. I'm a,
How many
genetically thin.
kilograms is that? Sorry for the rest of the world.
Oh, geez. So
Because I'm not very good on that.
I
Ah,
got a
shit.
calculator.
Ah,
So divide that by 2.2. So what is that?
that's
70
60
would
or
be about
something.
50. So it's about 60 kilograms, I think. Yeah, I think it's
Okay.
about.
Mm-hmm.
I was thin. I was very lean. And then
Yeah.
as I got older, I just kept getting heavier. And so I got up over 70 kilograms. I got up to about 75 kilograms, which was a lot for me. So I have coffee for breakfast with cream. And I just eat one meal a day. I eat dinner, usually starting at about 5. And then I don't restrict myself from 5 to when I go to bed, which is about 10. I eat what I want. But you find that over the day, your stomach seems to have shrunk. So let me tell you the reason. So first of all, there's a lot of negative papers on this thing, which is called intermittent fasting. But if you actually read the papers and not the newspaper articles, most time the fasting period is only 8 to 10 hours. Well, I don't think that's fasting at all. That's called going to bed. So
Exactly.
I don't
Mm-hmm.
view that. When you fast overnight, you start to become ketotic because you start breaking down fat. So in the morning, when you eat breakfast, that gives you carbohydrate in most meals, and
Mm.
that stimulates, as you know, insulin. And insulin is one of the things that contributes, and also the gut being distended, it contributes to hunger. So I allow myself to become ketotic during the day by not eating, just having my coffee with cream. And by 5 o'clock, I sometimes, for example, I have to remind myself to eat.
Wow.
So I find it useful. Some of my patients have done it and it's been successful. I do not have a study on it or anything like that. It's just what I've done it for 4 years because I got too heavy. Um,
Mm-hmm.
and I went from 168 down to 140, which was too little for me. And now I keep myself at 70 kilograms. So I got down to about 60, 66 kilograms. And now I let myself hang around 70 kilograms.
So you found it quite easy, did you? You didn't get very hungry, you said.
No,
So you have
I
coffee
didn't.
or cream in the morning and then nothing till 5 o'clock, and then you have whatever you like after that.
Yeah, I just eat dinner. And then, I will snack and I will do what I want and then go to bed and then get up in the morning and just have coffee. I love my coffee. Absolutely addicted. So I don't know about other people, but coffee changes my disposition within about 10 minutes.
Believe it or not, I don't drink tea or coffee. It's just kind of strange.
Well,
Um,
I'm in admiration. I don't think I could survive.
no, there's no particular. I've had one sip of coffee in my life, and that was it for some reason. And then I made tea for a while, and then I just couldn't be bothered. It's a hassle. You've actually got to do something. Okay, so I've got these questions here. Powell, Marino, differences on heart adaptations between low intensity exercise, tons of it, versus high intensity exercise. We've kind of talked about that. I guess we haven't talked about just he's talking about just rather than heart disease and things, just adaptations
Yep.
to
So
the.
it depends on your goals. Adaptations, doing a lot is going to increase your endurance. Doing intense is going to increase your oxygen uptake and your maximal capacity. If you're going to compete, you need to do both, especially if you're going to compete at long distances. If you're just trying to, like that song, the Bee Gees song, Staying Alive. If you're just staying alive, then I think the best thing is kind of a moderate intensity, like brisk walking, and a fair amount of it.
I think he's talking about, that makes total sense. I think he's talking about specifically adaptations to the heart.
You get much more adaptations out of the high intensity stuff, no doubt about it.
Exactly. Which makes sense because you're pumping more blood through, as you said. Okay. What general principles should guide athletes who have coronary artery disease and monitor their heart rate? Age 67, this is their own experience. Age 67, I routinely exercise 2 hours a day, but failed an exercise stress test that was part of a routine health check. An abnormal ECG started at a heart rate of about 130, which felt like easy to moderate. I mean, I'm sure it's hard to without other information.
Yeah, not exactly sure what to say, but symptoms are the most important thing. So, if you had EKG changes at a heart rate of 130 beats per minute, what you want to do is you want to exercise at levels below 130 beats per minute. But the most important thing is pay attention to your symptoms. And you don't want to push yourself too hard because, as we said, when you exercise intensely, your risk goes up. You get more benefit from it, but you get more risk. You have to decide what's important to you.
That makes sense. Perfect sense. Okay, Greta Compton, who's been a great supporter of the podcast right from the start. Case history: ex-Ironman multiple times, now diagnosed with coronary artery disease. Had to stop training 3 years ago. Meds, changed diet, given the all clear to start training again. Ironman Nice 2025. Any adaptations to fueling required? Any other considerations? Thank you. Again.
No, I don't think there are any adaptations necessary for fueling that are different. I think the thing to do is to keep treating your cholesterol levels and your blood pressure and your possible diabetes if you have looked at that. Or, a lot of people have borderline diabetes and they don't know it. So be very aggressive about looking at borderline diabetes. We talked about that earlier, but pay attention to yourself. That's what you got to do. You want to pay attention to yourself. And then also remember, when you're pushing really hard, you got to say to yourself, is this worth it? Is this what because you do increase your risk. I don't say you're increasing your risk great, but you do increase your risk. And what matters in life is winning this race against some other 76-year-old important, or is seeing the great grandkids important? You have to make those.
Exactly. Right. Francois, does he still run? And if so, how fast? I think we've worked out that you cycled or run, is that right?
I broke my hip in a bike accident on the
Oh.
Boston Marathon course in 2012. What was happening is I was turning 65. So you can see I'm an old dude because I was turning 65. I thought I could do well in the over 65 age group. So I decided to take a year off. My son-in-law borrowed me a bicycle so we could ride the course. It was a little big. I think I caught going around a curve, and the rest is history. So I have an artificial hip on the right. I was told I could run if I wanted to, but I decided I would run from fires only. So I cycle.
So you're running into 2012. Now, ironically, that's when I broke my leg of femur, 2012. But I've just patched up screws and plates and but yours was so bad that you have.
I broke the neck. I broke the neck of the femur, where it inserts into the and it's hard to get blood supply into that. It usually becomes necrotic. So so I got it replaced. And you know what? I've been very happy. And also for me, I was 65. It might have been a good time to change, what I was doing in life.
Oh, okay. Well, I'm sorry to hear you had that. It was I broke the neck of femur as well, but it was just plate and screws and off I go. But maybe I was 3 years younger than you, lucky or something. But it must have been not as bad as well. Okay, this question: Are there any specific heart rate ranges that maximize left ventricle volume size, or is it just a matter of large, varied training intensities over time?
I think it's a matter of intensity and it's a matter of over time. And it probably helps to do it when you're young. Now, I don't know this for sure, but the heart is encased in a kind of a plastic baggie. It's encased in what's called the pericardium. And I often wonder if people don't get their heart as big when they start training older because the pericardium has gotten kind of stiffer from age. So I think, you should get younger and train earlier in your life.
Just thinking about that, is there any evidence for epigenetics? So, in case people don't know, genetics is the DNA and all that, but epigenetics is sort of the above the genes. So markers on the genes that can be passed on, but also, if you exercise early in life, there might be epigenetic changes that make your adaptations later in life more likely and things like that. Is there much known about that with the heart? Do you know?
I don't know about it, but what Glenn is talking about there for the audience is he's talking about the fact that you're more than just your DNA. Your DNA can be altered by the attachment of these things, which are called epi, in other words, on top of your genetics. And exercise creates all sorts of epigenetic changes. And there is some data. I am not an expert, so you have to look it up. But there is some data for such things that there's some suggestions that even exercising during pregnancy may have epigenetic effects on the fetus. I just saw an abstract, so I can't push that. But you probably do change yourself with exercise by actually how you change the expression of your genes. It's fascinating. So, we talked a lot about, and we've done this throughout, and I've been doing it. We've talked about deleterious effects, but what exercise can do is just remarkable.
Oh, yeah.
I mean, epigenetic stuff may actually be able to be passed on to some extent. So there's lots of, I don't know the answer, but it's a great question. So whoever asks it, you get an A just for the question.
Oh, that was me. That was not a question. That was me. So I get an A plus. Thank you.
Yeah,
I've actually.
It's your podcast.
There you go. Laurie Goodyear, I've had on from the Harvard Johnson Diabetes. She was talking about epigenetics, so with largely animal studies, exercising the mum, exercising the dad, and then the positive effects in terms of reduced diabetes risk in the offspring. And I've actually done those sort of studies as well. We put rats on a high fat diet, the fathers only on a high fat diet, and then the offspring had an increased chance of diabetes and things. And if you exercise them early in life, you could overcome that. So interesting. Now, Mark here.
I'm glad you gave a shout out to Laurie Goodyear because she's done remarkable work as you have as well. But and also I've been aware of some of the epigenetic stuff. It's just remarkable.
Yeah, so we found that even also if you high fat diet and then you exercise the offspring early in life, they can get over that problem that they have of increased diabetes. But also, even if you're born small for gestational age, again in rats, born small for gestational age, you have increased risk of diabetes. And we showed if you exercise them for 4 weeks early in life, you could reduce that. So it's really amazing stuff. If I say so myself with my own studies. Now, Mark here said, any medications/supplements that augment cardiac benefits of aerobic exercise, e.g. RAAS blockade, I should know what that is, lipid-lowering drugs, do the benefits of additional medication depend on the comorbidities?
It's a good question. So there are the RAAS is renin angiotensin, angiotensin, whatever.
That's what I thought. I thought renin angiotensin something. So I'm glad you said that as well.
But so there's basically what's called an ACE inhibitor in ARBs, angiotensin. There is some early data that these receptor inhibitors, these angiotensin receptor inhibitors, may be associated with better exercise performance. I don't use them for that, but in a lot of runners and athletes who are reluctant to take medications, if they have a blood pressure problem, I may suggest an angiotensin converting an enzyme inhibitor or an angiotensin receptor blocker. And say, look, there's some early data that suggests that these may improve exercise performance, but I don't think that's conclusive. The next question, are there other agents that can help performance? I don't know of over-the-counter things that can help performance. Now, you hear something every week, and that's because people make money selling you stuff. So, don't act like you were born yesterday. The only people that care about you are you and your mom. These people selling you stuff or selling you stuff. I hope I'm not picking on some advertiser of your program, but
I have no advertising on my program, none whatsoever.
So, if you get cholesterol problems and if you need a statin, we don't think that statins badly interfere with muscle in all our studies. But the key, so take the drugs you need. I don't know of anything that really markedly increases your performance except androgens, of course, and thyroid. If I did, everybody would be using them.
Okay, so you've been around for a long, long time, so you have a lot of general wisdom and things. So this is a more sort of general question. Your opinion on versus current evidence, what societal changes would facilitate more physical activity, e.g., better socio-structural changes, better bike lanes, pavements, free sports clubs for kids, or more focus on individual health literacy, fitness apps, TV shows, GP visits? It's a bit of a hard one, but
I'm a big, this is going to get every mother out there mad at me. But the school bus thing. I mean, the school bus thing is pushed by the companies that make school buses. I mean, now in the United States, a quarter of a mile, and you
really,
can get a school bus. I understand. So I've always been that it's got to be environmental changes that help make it easier to exercise. So sidewalks, encouraging. But if you were
kids
on the
to
school
walk to
board
school.
now in the United States and you tried to get people to walk a half mile to school, you would be in big trouble. And the entrance to the school would be totally blocked because everybody would be driving their kids to school. So it has to be environmental changes, but at the same time, it's environmental changes. We've got to make sure people know why we're doing this. The epidemic of obesity, the epidemic of diabetes, premature heart disease, weakness, people outliving their muscles are all good reasons to re-engineer our society.
Okay, now John Dyer, he asked a question we already discussed: can exercise cause heart calcification? But then lifters hold their breath, so Valsalva maneuver during a lift that increases blood pressure. Do you see an issue with this? So the old holding your breath while you're doing weights, which is a natural thing, right? It just happens
You
naturally.
almost have to, although you're told, to inspire when you're actually doing the major push and to expire when you're relaxing. So, I'm not an expert. And so the person to have asked would have been Ben Levine. There's been a lot of concern about just how high that blood pressure gets. There are reports of aortic dissection and rupture during straining maneuvers like that. So it's both theoretical and some reports, but not great studies. If you're going to lift those weights, your blood pressure is going to go up. It's part of the game. So, but that's all I can say.
Yeah, yeah. All right, so that's great. There's a bunch of Twitter questions that we've already discussed. So you did mention earlier some sort of sex differences. You said I can't remember what it was now. Is there much to think about there?
When you look at sudden death during exercise, it is not entirely, but it's mostly a male problem. Women don't die during exercise with any near the frequency of men. They do occasionally. It's not intensity. To some extent it's age, because heart disease is delayed in women. It occurs about 10 years later. So that and the older you are, the less likely you are to do vigorous exercise. I've often wondered if it's related to heart size. Women tend to have smaller hearts.
Oh, mhm.
Sudden death doing exercise is not entirely, but to some extent, a male problem, not a female problem. There are differences in cardiac adaptations to exercise training in men and women. Bigger adaptations in males, probably, not certain, probably related to androgens, testosterone levels, stuff like that. But all that stuff needs to be figured out. We don't know it
And
perfectly.
what about atrial fibrillation and coronary artery calcification, etc.?
That's both things. Atrial fibrillation from exercise doesn't seem to be a problem in women. The
Mm.
studies show that the fitter the woman is, the lower the risk of atrial fibrillation, all the way down. Men, the risk goes up as you start to get fit, and then it goes way up at the end. No, I'm sorry, I did that wrong. The risk is down in people that are fit, but then when you're very fit, it goes up. So some exercise in atrial fibrillation is good in men, but both the calcium and the atrial fibrillation is so far looks like it's a bigger issue in men.
Wow. And do you think that might be, I know you said the heart size, but estrogen, so after menopause, does it become closer?
Don't know the answer to that. The sudden, I don't know the answers to either one of those things, but yeah.
That's fair enough. Okay, so again, with the wisdom thing, my wife actually said this. Ask him this, experience. You've experienced so much. Is there some things you'd like to pass on, that you've picked up? I mean, obviously everything we've talked about has come from your experience, but is there something you'd like to suggest, I don't know, to junior sports cardiologists or, I don't know, probably listen to your 500,
Well,
listen to your, mm,
I actually have a lecture that I give on, how to be a clinician, because I was really never trained as a scientist, how to be a clinician and have kind of a research career. And the first thing is to do something that you love. I've always loved this. The second thing is to do something. Like a lot of people talk about doing things. A lot of the things that I
mm,
did that didn't look very promising turned out to be very useful. So you can't
just do it.
you don't learn anything. So you got to do something. I think
Mm,
one of the first things you should do is you should find something you're interested in and write a review paper on it. Once you write a review paper on it, you know where the holes are, and you also suddenly become the expert. I
mm,
have this thing called WWW, which stands with Work with Winners. Pick people to work
mm,
who are successful. Like I went to work with David Costill when I was a
mm,
first year medical student because he was successful and he was
mm,
publishing work with the other thing is with that work with winners thing is go and work with them. If you can actually go and work with them, if you can't go and spend some time, at least visit them. I call it
mm.
the field trip. Go
Yeah.
field trip with them. The other thing is write up what you did. I know a lot of people that did very interesting things. They never wrote the paper. I always tried to write the paper. And remember that it's not really done until the editor tells you it's done and it's accepted. So I think those are roughly some of my, trying to
Mm,
think if there were, yeah, that's basically it. And the other thing is, I was always, I think I mentioned this, I think I was always too competitive early on. And I've really, the best
collaboration.
is really to
Mm,
work collaboratively with others. You'll have the most fun. I've really become to admire the Icevogels and one of his physicians that works with him, Vincent, with a very large last name, anger and nervous, but they've done wonderful work, and they've been fun to work with.
so I guess working with winners means collaborating anyway, doesn't it? Because
Say that
working with winners, the WWW, is collaborating anyway, isn't it? It's not just doing things on your own; it's working
it is.
with others.
But, sometimes I see young trainees and they're working with somebody that really, talks a good game but never gets anything done. You want to really get beyond
Yeah,
that, so that you get with people that are interested in you.
and also you find a lot of these people aren't as scary to, it's like scary to contact David Costill back then. It's scary in theory, it's scary to talk to you, right? But people are often quite approachable, and you're better off having a crack, trying to contact these people to work with them or visit them than not. So it fits with your just do it sort of thing you said as well, right?
It does, but and what you're really talking about is getting a mentor. And if you can find, if you're a young person, you can get somebody that will help you. That's remarkable. I was lucky in that I've run into people during my lifetime who have helped me. David Costill helped me. Now I only spent 6 weeks with him, but he's helped subsequently. When I was at Brown University, there was a wonderful man who was an expert in lipids, had no interest in exercise, but he was wonderful in lipids. His name was Peter Herbert, and he made me a lipid expert. At Stanford, Bill Haskell, who was a giant in the field of exercise, and Peter Wood, who was the first guy to describe higher HDL levels in distance runners. So, nobody does anything alone. You really don't. And, I've always, as I've gotten older, I've really come to dislike the idea of the self-made person, because if you say you're self-made, you're taking all the credit for what happened to
Yeah,
you.
it's
But
true.
each one of us had high school teachers, that contributed a lot, and people along the way that contributed and collaborators. So I also think if you can get rid of the idea of being a self-made person, you're much more likely to help others and, to be gentle to others.
Mm. Right. All right. So that's good advice. Now, one question I've started asking people was this one. So because the idea behind Inside Exercise is I want to take on all the influences. They have all this misinformation. So there's all these podcasters and other sort of influencers and things that give all their own opinions on things. They're not an expert on it. So what like to do rather than giving my own opinions, I'm not going to give opinions on cardiology. I interview the experts and try and make it accessible. Yeah. So part of the idea behind insight exercise is take on misinformation from influencers. Is there something in your area which is annoying you in this regard? So stuff that gets bandied around about exercise in the heart, for example, that annoys you and you'd like to sort of address at the moment.
I guess my only real complaint is that everything is, I don't like to make things complex, but it is complex. And so what you often get from the newspaper is the headline, and it's often not really reflective of the true thing. So I like to ask people to don't look at the gusts of wind, but look at the wind direction overall, There's always things that blow different directions, but what's the overall direction of the wind? And for exercise, the overall direction of the wind is that exercise is very good for you. There are some interesting things that we're exploring, but overall, you should exercise. You should just question whether you have to try to get to Paris for free.
Exactly. All right. So I think you've sort of done a bit of a summary there, but what I'd like to do at the end is have some sort of takeaway messages that you'd like people to take away from this. So, you give a talk and it's like at the end, it's like, oh, I hope they remember these 2 or 3 things. What are your takeaway messages from
the takeaway message is don't try to be your own doctor. If you're worried about something with respect to any of the things we talked about, get a clinician that you trust and discuss it with them. 2, it does seem that lifelong endurance athletes more likely have coronary artery calcification, which doesn't seem to be all that worrisome, but it should be dealt with. Atrial fibrillation, which can be a problem. Bigger aortas, bigger hearts in general, even some little bit of fibrosis in the heart artery. The third thing is exercise has lots of good things that it does, but if your blood pressure is out of control or your lipids are out of control or your diabetes is out of control, think about using medications because they're good. And I guess the last thing is don't worry, be happy. No, the last thing would really be, make sure your goals fit with what you're doing exercise-wise. If your goal is to live longer, probably steps per day and all that would be enough. It wouldn't be enough for me. I want to do more. So, if you want to do more, what your goal is different. So it's all right to push yourself for that if that's what you want. But you get the most health benefits out of relatively small amounts of exercise.
Exactly right. Okay, well, I found this really, really enjoyable. You're a very approachable and fun guy to chat with. And I don't even know how long we've gone for, but I think it might be getting up near the David Costill levels. It's probably close to 2 hours now.
He's got 22 minutes on me. 7:08.
Okay. I'm sure we could fill that up as well. But yeah, it's been really enjoyable and I've learned a lot. So thank you very much for coming on.
Glenn, I'm flattered to be on here. I'm just pushing my blog, 500 Rules of Cardiology. It's
Do it.
primarily clinicians, but there's a lot of simple stuff in there too.
Great. All right. Thank you again. See you.
Oh, it's free.
It's free. Great.
Yeah, worth every nickel. Worth every nickel.
Free. So you said it's Substack, but often people have to pay and all that so you're saying it's all free.
You have to subscribe to Substack, but it's free. The subscription and my blog are free, but you do actually have to download it and that sort of stuff.
Yeah.
And it's easier for me to do Substack than it is to send out 1 million emails.
So you don't have a thing that after reading 5 of them, you've got to start paying $10 a month or something. It's all free.
Well, no.
It's fantastic.
No.
Okay. Thanks again.
Thank you.
Nice to see you. Okay. Bye-bye. I hope you enjoyed this podcast. And please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.